It's free on the website.
I just think that they'll want,
Okay, go to the website.
you know, like, see, I don't think I go to the right
Is it
because I'm always in like all, I'm
Just-
in team meetings every week. And so we're going to like psychology meetings, we're going to like the,
That keeps you. I just want a half a one.
keeps you fresh.
Here.
Fresh.
Right.
Right.
Original.
Yeah,
Yeah.
they probably want some pain.
That's a good quote.
Yeah.
No, I think
Take it out of context. I
Take
can
it
see
way
what
out of
happened.
context.
way out of context. This is not Cards from Humor.
As it was leaving my mouth, I knew something was wrong.
You're like reading it in now. Let it go.
It's not Cards from Humanity.
That's right. Oh, God, I love that.
God, that-
I learned so much on that.
Mhm.
I don't think I've done that. I got really burnt out at St. Joe's. We had it was like presidential.
Hello?
Hi, Ann.
And
I'll get
Hi.
your PowerPoint up.
Okay. I heard we don't have a, is it okay that you can't see me? I heard we had a, we don't have a, case yet. Do you want me to do a case? Because I can.
Well, one of the things that we were deferring to you is that we usually only suggest that a presenter talk 15, 20 minutes. And, you know, maybe 15 slides, and so you have twice as much. So either we split today into 2 sections, or we have you present the whole PowerPoint, and then next time do all cases, and see if we can't get the participants to send in cases with pain.
I wanted to get the only thing I talked to Brian a little bit about this. I just really wanted to get all the didactics in before I did the cases, just because they're kind of dependent on understanding why I'm doing them that way.
Okay.
Okay.
But I don't know. I mean, if you guys think that's not going to work, I'm
We can make it work.
Suggestions too. Okay.
We can make it
We'll
work.
just do the whole didactics. I think
Right.
I can get through them. We'll see. We'll see how
Okay.
fast they go.
Well, I would rather you make sure that people get it, and then, because we don't have a case then, and it's okay if we just do an announcement to begin with that we're doing it differently. So,
Okay.
sorry, just a minute. Oh, gosh.
I would,
Stop.
yeah, I'd consider it. And
Okay, now
kind of made it sound like they've already got.
can we hear? Okay, can you hear me now, Ann?
And
Mary did
Or did you?
after meeting with them on Monday.
what?
Mary Becker, I met them on Monday.
No.
I did not have that impression.
Oh.
Because she was trying to.
Can you hear me?
Yes.
Yeah. We got
Okay.
you.
Are you, do you have a camera?
No one's approached me, so.
I have one on my cell phone, but I don't have it on my computer.
Okay.
Well, let me.
You can sign on your phone. It is just, people just get a great deal out of being able to see, especially the presenter.
Okay.
We encourage everybody, even as participants, to sign on with their camera. So you're welcome to do
Oh,
it.
there it is. I got it. I can do it. I was looking for the link.
All right, great.
Well, I didn't know. I think you should.
Oh, thank you.
Okay. Can you see me now?
Yep.
Great.
I'm 2 different people, but that's okay.
Fancy. Yeah.
Oh,
Is it me or?
yes, we should highlight her face.
They're Bakersfield
And
donuts.
when you called
There's
in,
my face.
yeah. Well, can you do it? Andrew?
28.
28th and 42nd, 20th Avenue, 42nd Street, South Minneapolis.
When I had a salad.
Oh, actually,
A tiny salad.
then you can do it just perfect.
Yeah, they're like.
Do you want to advance your own slides, or do you want us to advance your slides?
They're the cheapest donuts.
I would love to advance my own slide.
Okay,
42nd.
then
Street?
Why don't you pull up your PowerPoint?
Yeah, right by like.
We'll have the
Oh,
first
okay.
we'll have the first few slides and then we'll share the,
Can you see,
Yes.
can you see, like, will I have to show my computer on my camera, or can you see my computer?
we'll see your computer. See in the bottom, I'm gonna walk you through it. In the bottom
Okay.
panel, you'll see that green box that says share.
Yeah, like I was just saying before you got here.
See the little,
Oh, share, yeah, okay.
yeah, okay, you click that, and then you find your PowerPoint among the options on your desktop there.
Going to a family and a large.
So I have to open it on my desktop, and then I share my desktop, basically?
Right. So you click on the one that you want, and then you hit share.
$20.
Yeah.
Okay.
You can try that now if you'd like.
Donuts are $4.
Yep, I'm just finding my
$14.
desktop, or my
And
thing.
they're too big and too heavy and sticky. Too much glam.
There's also too much going
I
on.
like less glam, less
Yep.
plain.
Give me a simple donut.
I'm from
That
the
size is
Midwest.
better.
I'm from the Midwest. I need something a little more small, a little less.
I just like it.
More basic, more basic.
I've had that. That was actually pretty good.
It is.
But I'm not,
No, I like to
Yeah.
straight up.
So there.
like if somebody gets a grand donut, I'm not gonna not eat it. You know, I'm just saying, they could have gone to Baker's Wife, had just as happy of colleagues and saved a bunch of money.
Yeah.
I had a patient who worked.
Okay,
There
do you
you
guys
go.
see it now?
Yeah, now you see it now, then you're in full control.
He's an artist.
Okay.
Oh, yeah.
So you can do your slide, present it as a slideshow.
Not kind of. He's a legit artist, actually.
Yeah, so I'm out of town. I'm leaving Saturday. I'm at APA is in San Francisco,
Mhm.
but I'm back Wednesday. So
Where in
Shouldn't do that to share it.
we're in San
Yeah.
Francisco, wherever.
Should wander around a little bit. Tell us what the streets are like.
Embarcadero?
No, I'm
Watch your step.
gonna be at the West.
Yeah, very much so.
Okay.
Watch your step.
Yeah, I love to hear updates on
Because there's poo everywhere.
San Francisco street life.
Okay, I'll do some
Investigative reporting.
I should have an Instagram.
You getting it?
My dog has an Instagram account. That's as far as it gets in our house.
Well, people love that.
My daughter,
Okay.
last year.
So you see what we're seeing.
set it up, and I'm like,
We're seeing the,
she's 11.
not your speaker view, so, not speaker view,
Dog,
but the one where you can see the
That's not
slides
what
on
I-
the left-hand side.
You should be a lawyer.
Yeah, that's not what's on mine right now. I switched mine to the actual slideshow, and I can't
she loves
see it
shots.
as the
Okay.
slideshow.
All right, so then stop sharing,
Be a nurse.
Okay.
It's not giving them.
and then when you go back in again, it will have the slide. It should have the
I
whole
get it.
slide.
Okay. Got it. Okay.
There you go. See
There
how
you go.
nice and clean that is? Okay, so
Yeah,
we may
wait, now
have
let me
the
see if
first,
I can advance.
Oh, thank you.
Oh, wow.
There we go. Got it.
okay?
Cool.
We'll have the first few slides with your title and the icons and announcements that will be shared before you start your presentation. Then you can go right into yours. So there'll be
Okay.
a moment to stop, share, and share, and that will be announced.
David and I go with.
Right after he says
Oh,
announcements
good.
about the cases for next week. He'll be asking people
Yeah.
to submit cases
I really like
for
Yeah.
next week as
I
well.
heard too. I slept right
It's fun.
through.
Okay,
Didn't hear a face.
so,
We wouldn't believe
yeah,
it.
you can put the head up. Well, just be ready to do the first three slides. Okay.
If you're,
My wife told me she knows how.
pulsing, you would wake up.
Hey, Ann.
Oh, yeah, that's true.
Hello.
Yeah.
Thanks for hanging out. I appreciate it.
Great. We'll stop the share now, Ann, from your side.
What?
We're going to stop your share right now, and then we'll start it again. Okay?
Okay.
There you go.
Got it.
Brian gets a chance to see everybody, and people can see him then, too.
It's not just me. People come to see these guys.
Cam said
It's all about the shine. I got no shine.
Shine, you got a bookend shine right now. Just bookend them.
Whoa, the light! Ah, my eyes!
Where are you guys even in Hennepin right now?
We are in the basement.
Mm-hmm.
We're in the hall.
I
We
figured.
literally hang out
It
in the
looks kind
back.
of basement-y.
It's the back corner of the basement.
We're by an elevator.
Oh.
An elevator shaft,
Cool.
an elevator equipment room, and
Yeah.
Sort of a bunker.
But it's our
Romantic
bunker.
like that, bunker.
Bit of a-
Um,
At least you're safe if there's bombs.
That's true. And we're right next to the pharmacy, so there's plenty for us to make us feel better.
It's kind of like the Situation Room.
We don't need it because we have donuts.
That's true. That's true. And we have donuts.
Preemptive.
And we have donuts. So I want to give a shout out. Hey, Chris Mattson. I don't know.
Hi. I'm just figuring out my new machine here, and I don't have video at this point yet, but glad to be at my first Hennepin Echo.
Thanks for hanging out. Where are you now, Chris? Are you in Wisconsin or Duluth?
I'm sitting in Ashland, Wisconsin at the moment.
Oh,
Nice.
beautiful.
Nice.
Do you have a nice view, Chris?
Why would I want to take my eyes off Brian?
Oh. There's lots of reasons for that. There's lots of reasons for that.
I can see the parking lot from here, I guess, too.
Got it. Are you in Chequamegon, or where are you in Ashland?
I'm in the Essentia Clinic, which is attached to the MMC hospital.
Got it. Cool. That's awesome. I hung out there for 6 weeks in my med school years.
Yeah.
I know that place very well. Yeah.
And I'm nearby my grandchildren and my daughter, whose birthday is today and is graduating from nursing school and getting her pinning ceremony this evening.
Oh,
Wow.
Congratulations.
Congratulations to the Mattson
I'm
family.
proud. I'm proud. Thanks.
That's awesome.
Okay, I'm going to mute and I'll be listening.
Sounds good. And hey, Swang, I imagine Swang's hanging out perhaps from Ebenezer. Swang, are you there? Swang Notup is one of the family medicine docs at Hennepin who works at some of the local nursing homes with the residents. Thanks for joining us, Swang and crew. If you have any folks that are with you today, if you could just send Roxanne a chat message to let us know who's joining you. Hey, Shelly.
Hello, can you hear me?
Yes, how are you?
Hello, I'm great. This is my first ECHO meeting. I'm a new employee at Tri-County in Wadena, so
great.
just today for the first time. I'm getting a video, a web camera sent to me, so I'm not able to be on video, but I can hear you. So.
Awesome. Well, thanks for joining us from Wadena.
Thank
it's
you.
great to have you. I might reach out to you later. Are you prescribing Bupe, or what's your role in the clinic up there?
I'm just an RN health coach, starting up the opioid program here at Tri-County. So just the initial phases.
So by just RN, you mean like you run everything?
Yeah.
Right. Will be. I think we have 6. This is my 3rd day, so I think we have 6 Suboxone patients right now currently.
Awesome.
Awesome. We'd love to help.
Awesome.
Yeah, let us know how we can support you, Shelly.
Shelly, this
Thank
is Tim. I'm the RN here of our clinic. If you need any advice or whatever, you can contact me.
Awesome. Thanks. Great to make that connection.
Well, no, the email came from me. I've sent a lot of emails to a lot of people.
Hey, Valerie.
You said
Just
you're
let you know,
Stephen.
Valerie, you're live. Hey, Valerie.
Okay.
Thanks for joining us for Minnesota Recovery Connection. Just to let you know that your phone is live and your mic. We'll probably, just FYI, you can either mute yourself or we'll try to take care of you if something pops up.
Yeah.
Hey, Peter. Peter's joining us from Neuroclinics.
Yep, thank you.
There you go.
You got it.
Peter's an intern there who works for the pain clinic, formerly known as MAPS.
Why did you think it was a different day? I'm
Could
sorry.
you mute Valerie? Sounds like she's missing. Thank you. Hey, Peter, thanks again for joining us.
Yeah, no, it's a pleasure.
I imagine this topic is going to be a sweet spot for you.
Absolutely. I've been looking forward to it.
Awesome. And then for you and for everybody else that's already joining, I think this is one of the ones where actually we're going to do a little bit different format today. We're going to have, Anne's going to be doing primarily all didactic today with pretty just a minimal amount of case review today, with the purpose of next week she's going to be back and we're essentially going to do all cases for the entire time. So if you have cases where you're wondering, should buprenorphine be a good option, whether it be you're already thinking about it, or after this talk, you're kind of like, maybe that might be a good idea, please send us cases. And I imagine, Peter, you probably have no shortage of interesting cases that you're thinking about. So please, if you wouldn't mind kind of putting that on your docket. I would love to kind of have more of a conversation with folks that from all over the state that people are thinking about how would this work out.
Okay.
Awesome. Thank you. Hey, Sarah Rivstad, or Rivstad. I think I said that wrong. I'm sorry. Rivstad.
That's right. It's Ristvit.
Ristvit. Oh, close. Where are you calling in from, Sarah?
Hortonville.
Awesome. This is the first time we're actually seeing each other. Other people have called in from Ortonville, but we've never had a video, so welcome. Thanks for joining us.
Yeah, thank you.
Hey, Ray. Ray Christensen is joining us. I know I've seen you before. How are you doing? Excellent. And remind me, Ray, where do you practice out of? I can't recall.
He's muted.
He's muted on his side. If you wouldn't mind sharing, Ray, I'd appreciate it. Hey, Ray. Oh.
I work in Moose Lake 1 day a week. I work for the University of Minnesota Medical School.
Awesome. Thanks for joining us. I see Helen Thomas is joining us from, I think that's the North Point office, perhaps home.
Yep, North Point. Yep.
Got it. Thanks for hanging out, as usual. And hey, Dr. Amsterdam, Jamie Amsterdam joining us. And I think, who else is joining us now? I see Kelly Logue joining us. Hey, Kelly, thanks again for joining us.
I don't know the GM Hunter.
And GM Hunter, I think that's a new person for us.
Okay.
I don't know if you know what your sign-in name was, GM Hunter. Perhaps let us know if it comes up.
That's Wendy, Brian, that's Wendy Hunter from our pain clinic at Health Partners.
Oh, gotcha.
A nurse practitioner that works with us. Yeah.
Got it. Hey, Wendy, thanks for joining us. Thanks for the down low, Anne. I appreciate that. You can text her and let her know that she's GM Hunter. And then I know that there's a couple people that are continue to pop on, but just for the purposes of today, since there's a lot to get through, I'm going to kind of just jump to our announcements. And actually, as we kind of transition, I'll just kind of have us go around the room here to let you know who's sitting around the table. So, Helen, would you mind just starting it out?
Sure. Hi, Helen Wood. I'm a psychiatrist. I work with our primary care behavioral health teams in family practice clinics, and I have a small private practice as well where I do provide MAT.
I'm Cam Weaver. I'm a clinical psychologist on the team. I also work in primary care behavioral health, servicing our internal medicine clinic and our coordinated care center.
And Brian Grant, I do both primary care and addiction medicine.
Nathan Erickson, drug counselor, Hennepin County Drug Court and the Addiction Medicine Clinic here.
Tim Greer, registered nurse and bringer of donuts.
Roxanne Kibben, project coordinator.
Katie Bodner, HCMC intern, LADC.
Charlie Resnikoff, Addiction Medicine. We'll call this the Peanut Gallery.
Perfect. Perfect.
So the Peanut Gallery.
I do not need a peanut gallery.
Great. So and a quick shout out to Hey Twyla, thanks again for joining us. And a couple other people joined us. We'll kind of just jump in. A couple quick announcements before we get to Dr. Ann Pilkis joining us again. For those of you who are at the boot camp, she had one of the highlight talks there, but she's joining us again for, I know, a talk that is frequently discussed and requested, so I'm looking forward to it. Here again, just remember, it's easiest for you to manage the audio on your side. So if you are on phone or other mic, please use the mute on your side. If things come up, we can mute you, but it's just a lot harder if you have something to say or share for us to kind of go back and unmute. So please manage the sound on your side as much as possible, then it's easier to have a dialogue ongoing. Otherwise, if we do get into any patient discussions, please make sure to keep it no personal health information in order to make this just a learning forum so we can have free discussion. But please avoid any case specifics as we discuss going forward. If you have any other questions, you can always use the chat function. I know people are already starting to use that, or you can always just kind of wave your hand and we'll get back to you real quick. I think that's kind of the gist. As much as possible, please use the video. I think it's easier and helpful for us to get a sense for who's here and build a community across the state as we kind of keep working together and supporting each other. Here, a couple cases needed, as I mentioned before, just real briefly again. We're actually, Anne's going to kind of do mostly didactic today and kind of a change in our usual format, with the intent that next week we're essentially going to do all cases for the entire hour. So please, if you have cases, people that are on high-dose opioids, you're wondering is BUP a good idea, maybe addiction, maybe not, kind of that gray area in chronic pain syndromes, please send us your cases. There's a link here. It's actually super easy just to do it online. Please send us your cases so we can have that discussion. And then finally, kind of end of May, Cam's going to be giving a talk, detangling differential diagnosis. He did that for the alliteration.
Yeah.
But really it's kind of saying, kind of building up what we did a little bit the other week on documentation. But when you get into that mental health history, how do you really untangle some of those things that are oftentimes overlapping, and why should you? Why not just say anxiety unspecified? And I think Cam's going to kind of dive into a little bit more of the details of that, both how do you do it and why should I care? The Little Falls Echo, for those of you that don't know, CHI or Catholic Health Initiatives in St. Gabriel's at Little Falls, Minnesota, they have their own echo that does a ton of great work on opioids and addiction. This is the next few. So Murray McAllister is going to be joining them on the role of pain rehab next week. They do Wednesdays, 12:15 to 1:15. And then Dr. David Ring is going to be joining them a little bit down the road to talk more about some of his, I think it was peri-op work, if I recall. I think that was it for our announcements. Anything else? So we're going to pass it off then to Ann Pilkus, who's joining us from Health Partners today. Yeah, it's all you, Ann. Go for it. Oh, you're muted.
You gotta unmute the.
I'll unmute her, see if that works. Oh, I should do it too. Oh, I keep doing it, or no?
There we go.
There we go.
Did I unmute? Can you hear me?
Go.
You can hear me now?
Yep, we can hear you.
Okay. All right. So yeah, I'm going to try and get through these, and then maybe if somebody has some questions, we can get through them. I have more slides than normal, but this is kind of a complicated topic, and I kind of wanted to get through kind of like why we do these things before we went into just how we do them. But I do have some specific how do you do it in this slide set too. So if there are questions, don't hesitate to interrupt. Okay, so my name's Ann Pilkus. I'm internal medicine and addiction medicine. I work at Health Partners in the pain program at Regions and a treatment center called Sage Prairie in Eagan that my family owns. I heard that at the Hennepin County provider meeting for the treatment programs that my dad goes to because he's my clinic manager, that they call him the Sage Prairie Dad. So anyways, I thought that was funny. Okay, so let's go. I cannot advance. Okay, how am I advancing? Okay, I don't have any disclosures, but I will use some off-label indications and brand names. And specifically, I'm going to talk about using buprenorphine naloxone for chronic pain syndromes. Okay, so first I just want to go through, I mean, the reason that we're here today, the reason that we are in the position where we want to get people to buprenorphine is that we have all these patients on opioids for chronic pain syndromes, and I think that it's important to just review, do we know that the opioids are worth the benefit? So this 2018 paper from Aaron Krebs at the VA in Minneapolis, 240 patients with chronic knee or back pain. They had no improvement or function over 12 months in the opioid group over the non-opioid group. The second one is 2017, again, Krebs, and this is discontinuation. So do they do better when you discontinue them? And it was a meta-analysis, so there were 67 studies, although most of the qualities of the studies were low. But improvement was reported in pain severity, function, and quality of life in several fair quality studies. So I think, and then there's more. There's this one from 2019 that talks about discontinuation and effect on quality of life and healthcare utilization. Not discontinuation, but management on opioids only, NSAIDs only, or both. Opioid only group had lower quality of life, greater utilization of health services. And then this 2015 one about the risks of opioid therapy for chronic pain. Of course, everybody, I think, has seen this one now, but the higher the dose, the higher the risk of overdose. And then this is one of my favorite ones that shows, this is from 2013, but it shows the purple bars are the change in morphine equivalent doses, and the red bars, or the kind of mauve bars, are the change in pain scores. So it's showing that the higher you go, there's no difference in the pain scores. You can go up to 500% of your initial morphine equivalent dosing, and it doesn't change pain scores. Of course, this N is very small, but I just think it's very illustrative of the fact that at the end, we really do know at this point that opioids don't change pain outcomes. They are dangerous, and they lead to overdoses. So then we want to know, well, do we know who will misuse? Can we tell who is going to be addicted? Can we figure these things out either before we start people on opioids, or if we inherit them and they're on opioids? And the answer is we have some good screening tools. We have some good things that can predict, but it's not foolproof. So this study compared we have things like the SOAP and the ORT and the DIAR. The best is a clinical interview combined with the long form of the SOAP, and the long form of the SOAP is very long. But probably a good one is a clinical interview, or just the SOAP alone. But again, you'll see the DIAR and the ORT, which are pretty short form. Those ones have pretty poor sensitivity, and this is to predict aberrant behaviors, not necessarily to predict diagnoses of opioid use disorder. And then this one was from 2018. It was a review, but it's kind of looking at if we can predict who misuses. And of course, we know that higher doses infer a higher risk of overdose, but they don't necessarily infer a higher risk for a diagnosis of opioid use disorder. We know that males, people who are younger, who have a personal or family history of substance use disorder, are more likely to misuse. But there's a weak association between pain level and misuse. So there's always that, I think there's kind of a myth out there that if somebody is in more pain, they're more likely to misuse. But this review sort of discredits that it doesn't necessarily mean that they're more likely to misuse if their pain level is higher. But the strongest indicator for misuse is a negative affect. High levels of anxiety, catastrophizing personality disorder are also are highly predictive of aberrant behaviors or misuse, but negative affect is the strongest indicator.
Hey, Ann, could I cut in for just a quick sec?
Yeah.
A question that came through on the chat. When you mentioned that that Helen had, I don't know, Helen, if you want to just share actually you're eating, let me jump in for you. But Helen just had a question, and she's mid-bite. Was in that survey you're kind of looking for aberrant behaviors? When you had clinical interview, was that a standardized interview, or was that just kind of general gestalt from people having general HPI?
It was a structured clinical interview with a psychologist.
Thank you.
And I think it was a standard. I think it was a structured standard clinical interview with a psychologist. Got it. Thanks.
Problem.
Yep. Okay. So then once we then decide if they are misusing, then I think the next step is deciding, do they meet criteria for an opioid use disorder? Because that's of course going to change how we treat this situation. And this is people who are on chronic pain meds. Do they meet criteria for an opioid use disorder? So I mean, everybody here has probably seen this, but I think it's important to remember that just tolerance and physical dependence is not enough to create a diagnosis of opioid use disorder in the context of chronic opioid therapy. So because everybody has tolerance and withdrawal, no matter if they're on chronic opioids, so it has to be that plus something else. And in people who are on opioids for chronic pain, it's really hard to tell sometimes, and it's hard to get to it's hard to ask these questions sometimes. I think when we're in addiction, sometimes we have the luxury of, I don't know if it's a luxury, but people coming to us and saying, I need help me, I'm addicted to opioids, or I have a problem with opioids. But when you're in the chronic pain community, and I think this is a huge deal, they're not looking for help. They don't think they have a problem. And it's up to you to say, well, I think they do, or I think they don't. And how are we going to treat that if they do or they don't, right? So I think we just need to think a little bit about chronic pain because it affects the way that we treat it and affects how, why this topic comes up, whether buprenorphine is the right situation or not. And I'm going to talk, can you guys see my pointer? Yeah, okay. So I'm talking more about this end. So if you just look at chronic pain in general, you've got kind of anatomic, you've got inflammatory, you've got neuropathic, and you've got centralized, right? And centralized is that funny thing that we don't really know where it comes from, but we think it comes from the brain, right? But really in reality, every chronic pain syndrome is really kind of an overlap, and every chronic pain syndrome has a central component of each. There are types that are more central, like fibromyalgia, but there are types that are less central, that have less of a central component, but every type of chronic pain syndrome can have a central component, and almost all of them do. But that's kind of where I'm focusing this, because that's where I think the meat and potatoes of this pain population is. So central sensitization is, when you're talking about people with central pain, it's not the whole thing of what central pain is, but it's a giant portion of it. And central sensitization is just an amplification of neural signaling in the central nervous system. It's identified by what we call hyperalgesia and allodynia. Hyperalgesia is something that's painful, is more painful than normal. Allodynia is something that is not painful or shouldn't be painful, feels painful. And then the coexisting symptoms are fatigue, sleep disturbances, mood disturbances, etc. You guys have seen this patient before. So how does central sensitization happen? I think it's important to understand how pain happens and then how central sensitization happens. Changes occur both in the ascending pathway. So you have sensation, you have ascending pathways, so getting from the skin through the spinal cord, up the spinal cord to the brain, the ascending pathways. They happen in the descending pathways. So the descending pathways are kind of turning pain down, right? And then they also happen in what I'm calling interpretation, meaning what does this pain mean in the context of my environment, in the context of my mood, and just interpretation. And okay. So I think what is important to know is the interpretation, the changes that occur in central sensitization in number 4, in this interpretation part, are things like a hyperactive amygdala. So you're kind of always on guard, always hyper emotional. A hypoactive prefrontal cortex, right? It's about difficulty with impulse control, difficulty weighing risks and benefits. And then you get changes in the mesolimbic dopaminergic reward center. So with acute pain, you have acute pain activates dopamine in the mesolimbic reward center, right? So you get sort of this, you get acute pain and you get an activation of dopaminergic neurons, and you have sort of it's how your body sort of tamps down pain, right? But if you have prolonged pain, you get a prolonged activation of dopamine in the mesolimbic reward center, and you get decreased dopamine receptor availability in those areas, right? These are all exactly the same things that happen in addiction. So, but in addiction, they don't happen because of prolonged pain. They happen because of continued use of a substance. Okay, so all of these in this number 4, this interpretation area, they're very, very similar to what happens in addiction. Okay, so now let's add some fuel to this fire. We're going to give this patient who has all of these brain changes, including these ascending pathways and descending, these changes in ascending pathways and descending pathways, and all of these changes that already occur in addiction, we're going to give them some opioids. So they already have that overstimulated amygdala, the hypoactive prefrontal cortex, the low mesolimbic dopamine, and for a short time, the opioids cure that deficit, right? It's the same thing in somebody who because of life stressors has sort of, or ACEs, has a low dopaminergic load, and all of a sudden they take opioids and it just cures everything, right? But over time, of course, the same thing happens. They begin to reinforce the changes, they make them worse. And by this time, they're both the cure and the affliction. Do you guys know what I mean by that when I say that? You get to a point where it feels similar to what people say in addiction. Okay, but we also have to remember that opioids also change transmission and inhibition, right? And they do that so they don't just change the brain, they change the spinal cord too, by increasing spinal dynorphin, which is a kappa agonist, and by increasing spinal glutamate and NMDA receptor activity. So they're changing both how the brain works, how the brain interprets it, and how the ascending and descending pathways send signals to the brain and to the nerves. Okay. So how do you reverse those changes in central sensitization, and especially central sensitization in somebody who is already on opioids? So I ask, how do we reverse them in addiction, right? How do we reverse some of these changes in addiction? In addiction, we use medication-assisted therapy. We re-regulate these brain changes. We use medications that are very long-acting, that have a limited tolerance, that help control. They don't have those ups and downs of withdrawal and euphoria cycles, and they re-regulate that HPA axis, the cortisol axis. So then, how do we use that to know what we should do in central sensitization? And OIH is opioid-induced hyperalgesia. Sorry, I didn't define that. But basically, that's central sensitization that's related to opioids, right? That's that second thing that I talked about here. That's this, right? So buprenorphine can help re-regulate the brain changes just the same as they can in addiction, right? So if you have somebody on Percocet, or you have somebody on oxycodone, lots of short actings, or some short actings and some long actings, they're still going through that up and down phases, and they still have dysregulation of the HPA axis, and they're still on those that euphoria and withdrawal cycle. But the nice part about buprenorphine specifically is that it can also help re-regulate those spinal cord changes. So buprenorphine is a kappa antagonist, and it's an NMD antagonist as well. So you can see that it also changes. Oops. It also helps change these two things, the transmission and inhibition. So you've got a couple positive things. Methadone is an NMDA antagonist, so it also has some positive implications in opioid-induced hyperalgesia or central sensitization related to opioids. So this is a study from 2014, high-dose opioids to bupe conversion reduces pain scores and improves quality of life. So it was a chart review before and after conversion to buprenorphine. The high-dose opioids were between 200 and 1,370 morphine equivalents per day. They were converted to bupe. I don't know the doses of the buprenorphine that they were on, but I suspect they were equipotent. The mean pain score after 2 months decreased from 7 to 3 or 3.5, and the quality of life scores improved from 6 to 7. So that's a positive look at it. This one's from 2017, and this is measuring pain sensation in patients transition to bupe from high-dose opioids. And this is 20 patients transitioned to bupe. And those ones that were on higher doses, over 100 morphine equivalents, experienced decreased pain sensitivity, improved fibromyalgia survey scores, fewer neuropathic features, less catastrophizing, fewer depressive symptoms, improved functioning. But all these things return towards baseline at 6 months. Okay, so I think that's important that we know that it may improve these things, but you may only have a short window of time to really that they may only still occur for a short window of time, and I'm not sure why that happens. This one's from 2017. This one's around post-operative course, but I thought it was kind of interesting. They took people who had major lung surgery, and they got remifentanil perioperatively, and they gave them either buprenorphine or morphine post-operatively, and then they tested punctate hyperalgesia around the surgical site on post-op day 1 and for 3 months afterwards, and it was worse in the morphine group. So and post-op pain scores were better in the bupe group, but at 3 months they saw no difference between the groups. So again, it seems like short term it does have some implications, but long term not necessarily. These people were not continued on opioids, so they were short-term opioids post-operative. So then so now that I've sort of presented all this science, or if you can call it that, what do I actually do if I have somebody who is on high dose opioids and I want to transition them to bup, or I want to taper them off opioids because I know now that opioids are not a long-term management solution. So this is kind of my process. I do a risk stratification, which helps me determine the length of the taper. I choose which opioid I'm going to use in order to taper them off. I think about how the pain will be managed while we are tapering the opioids. And then I think about risk management, and that sort of includes number 6, which is what do I do when stuff happens? So I have to change the plan when stuff happens, and how do I know what to do when stuff happens? So this is a risk stratification table that I made a couple years ago, but it still has some good points in it. Basically, the length of the taper is determined by the risk. Okay, so if you're in a high risk, like if you have identified somebody who is addicted to opioids and you do not have, and they don't have acute pain, and you don't have a buprenorphine waiver, so it's not going to be just easy to switch them over, then you basically shouldn't be prescribing that person opioids, right? Or if you have somebody that has an active sedative addiction or an active alcohol addiction and no acute pain, that person shouldn't be getting opioids for chronic pain. If they have acute pain, it's a little bit more complicated, but for chronic pain, they should not be on opioids at all. And I would say length ASAP, I think 1 to 7 days. And then if they're a high danger, and again, if you don't have a buprenorphine waiver and you think that maybe they're addicted to opioids, but you can't really tell, they have multiple aberrant behaviors, or they have just other reasons that put them at a high risk category, I would say pretty short term, within a month, to get them off of opioids. Medium term would be somebody that has some aberrant behaviors, but you can't really diagnose addiction. Maybe they have some severe medical or psychiatric risks or something. They're just on a really high dose or something like that. That would be medium term. And then long term is somebody who's, just probably shouldn't be on opioids, or you're not getting the risk or the benefit, or you're not getting any benefit anymore. And I just want to clarify with this table that the risk definitely can be mitigated if you use a buprenorphine product. So the length can be extended. So even if I have a medium or a short term, or a medium or a short term that would, like a high or a medium risk patient, if I get them on a buprenorphine product specifically for the chronic pain taper, I can extend that time frame because they're on a safer product. Okay, so then I go back to my what should I do, and I'm at number 3 for opioid choice. So what opioid should I use? I always consider the safety of safety is my number 1 concern on all of this. And then if they, safety is considering, what age are they? Do they have comorbid diagnoses like psychiatric diagnoses or OSA or COPD, or cognitive issues that they can't take medications appropriately or whatever. And then cost is actually a big decision maker for me, because I work with patients who, some of them have really high deductibles. Some of them, you guys work with these same patients. If they're on Medicaid or whatever, some of them won't cover these higher cost medications. And then, of course, the diagnosis, if I can actually diagnose opioid use disorder versus if I cannot diagnose opioid use disorder. So still on which opioid should I use? So first I make a decision of short versus long acting, and then I make a decision of buprenorphine versus not buprenorphine. And I'm really, honestly, I'm always going to choose long acting. And I always choose long acting basically because I am an addiction medicine doctor, and I think short acting things are reinforcing. They also give you lots of cycles of withdrawal, and like withdrawal and not necessarily euphoria, but ups and downs. And I think that those things, if you go back to those brain changes, I think those things are reinforced with short actings a lot more than long actings. And then you ask yourself the question, okay, if I'm going to do a long acting, do I want to do it scheduled or do I want to do it as needed? I take away all as needed medications, and I do that because it just reinforces pill taking behavior. Really what I want to do is I want to move them away from I have a pain, I need a pill, to this pill is there to prevent pain, but also to help me taper off opioids. So a lot of times people will come in and say, I need a pill for my pain. And I try to move them away from that to this pill will help you taper off opioids because opioids are making your pain worse and they're not the best way to manage your pain. And I just reinforce that. But if then I give them as needed pain medicine, that is the message is muddied. So I always use long acting, and I don't use any as needed prescription pain meds. Okay, so then you want to make the decision of, do I want to use a buprenorphine product or do I want to use a full opioid agonist? And I just go with safety. If they have aberrant behaviors but you can't diagnose an opioid use disorder, if they have an opioid use disorder, or if they have comorbid or age issues. So when I use a long-acting full agonist, is usually somebody who's youngish, healthy-ish. If they're medium or low risk, if they have very few aberrant behaviors, it's generally lower cost than buprenorphine products, although that's not always the case. And they definitely don't have any opioid use disorder diagnosis. The choices are extended release morphine, extended release oxycodone, or the three that I choose are generally those three, methadone. There are other ones like extended release hydrocodone or tebentadol or tramadol or fentanyl patches. I have difficulty with those ones due to cost or prior authorizations, or fentanyl patches I don't like to use because they're really hard to taper. But extended release morphine and extended release oxycodone are nice because they can be, especially the extended release morphine, can be inexpensive. But I think one of the things that we have to remember, even in these extended release formulations, they really still only last 6 to 8 hours. And almost everybody will tell you that. And even in the OxyContin trials that we've seen, they knew that OxyContin only lasted 8 hours, and so they knew that it reinforced those ups and downs. So I do think that they need to be dosed TID. I use methadone quite a bit, but you do have to have extra caution with methadone. You have to understand how to dose it and understand how to convert it. And I think I use extra caution in kind of higher frequency monitoring with those patients. But it's been a really great medication for me to help taper people off opioids. And I especially like it in those kind of, once I get down, if say I'm using extended release morphine and I get down, or extended release oxycodone, and I get down to, like 10 BID or 10 TID of oxycodone and of OxyContin, and I just can't get any lower. I use methadone sometimes because I can use the liquid and I can taper it and wean it just down to teeny little doses. So I have some patients right now who are like on 1.5 milligrams twice daily of methadone. And so then I wean them down to 1 twice daily. So it's a really nice, just sort of smooth taper medication. And then what do? I convert their total daily requirement to 1 long-acting opioid. I initially decrease it by 10 or 25% just for cross tolerance. If you're using the same product, you don't necessarily have to do that at all, but I do it with everything. I stop all short actings, and then I just slowly wean it by about 10% every 1 to 3 months. And I do it based on how they're feeling that month. But I continually push them, but I only push them within that 1 to 3 month range. So, and once I hit the 3 month range, if we can't get anywhere further, then I generally think, well, maybe I need a different product. Okay. And then this is when I would, so that was what I do when I use a full agonist long acting for the taper. This one is, what do I do when I use a partial agonist or buprenorphine for a taper, or if we're talking about opioid use disorder, if I'm talking about maintenance. So the profile with this person would be medium or high risk, or they have an opioid use disorder. They're older, they have more comorbid diagnoses, but they do have a higher cost, and there are definitely more prior authorizations. So I'm going to run through the choices available, and this gets confusing all the time because they're all buprenorphine, but they're all in sort of different forms, right? So we have buccal buprenorphine, and buccal buprenorphine is also called Belbuca, and it's FDA approved for pain conditions only, not for opioid use disorder. The dose strengths are between 75 and 900 microgram films. The highest total daily dose that you can get is 3 900 microgram films per day, or 3.6 milligrams. Then you have transdermal buprenorphine, which is also known as Butrans. The top one, Belbuca, does not have a generic that I know of right now. transdermal buprenorphine just came out with a generic. So the cost things have gotten better over the last several months. So anyways, transdermal buprenorphine, otherwise known as Butrans, also only has an FDA-approved diagnosis for pain. It goes from 5 micrograms per hour to 20 micrograms per hour. So the total daily dose max you can get is only 0.48 milligrams, okay? Then you have sublingual buprenorphine naloxone, which is basically Suboxone. The FDA-approved diagnoses are only for opioid use disorder. And then you have sublingual bupe, which is also known as Subutex, which again is only opioid use disorder. You guys are probably familiar with the dose forms of that, but I have them listed over here. You've got generic films, generic tabs, name brand films, name brand tabs, a different brand Zubsolv tabs, and a different brand Bunavail, but those are buccal films, but they're not the same as Belbuca. They're different dose strengths. They correlate more with the 2 to 8 milligrams. Okay, so those are the choices. And then what do I do? What's the procedure? Again, it differs with the product and the diagnosis. So if the diagnosis is opioid use disorder, you just do it per protocol, and you use a product that is only approved for opioid use disorder, like buprenorphine naloxone, like Suboxone. If the diagnosis is chronic pain, again, it's just going to differ by product. So you calculate the 24-hour dose requirement, and you convert the total daily dose to a buprenorphine only product. I still do an initial decrease of 10 to 25%, and then I stop all short actings and as needed. So this is where me and the package insert diverge. So you're going to have to do some sort of induction, right? But the package insert will tell you, well, you don't need an induction because you want to get your patient down to 30 milligrams of morphine before you start Belbuca or before you start Butrans, the buccal or the transdermal buprenorphine. The problem with that is that if I could get them down to 30 milligrams of morphine, there would be no need for this. So I don't do that. I convert the entire thing to a total load, a total 24-hour dose, and then I have them stop it for 12 to 24 hours, and it's generally overnight. I generally don't need them to do a full induction. I've been doing this now for 5 years, and I've never had anybody have any sort of precipitated withdrawal. And I suspect that's related to the fact that these doses are much, much lower than heroin, converting heroin to Suboxone. So even when you do if you want to do the 30 milligram thing, you'll still need to have them stop it overnight anyway. So I generally just do a stop overnight. And then the same sort of thing, you decrease it by 10% every 1 to 3 months. The nice thing about the buccal buprenorphine, the Belbuca, is that it comes, if you have somebody who's on, if you go back here on, 2 milligrams, you can go down by 75 micrograms if you want. It's very, very nice. It's a very, very nice smooth taper. Okay, then how will the pain be managed? Well, the long-acting opioid product or the buprenorphine product will calm down those brain changes and those spinal cord changes. So you've got sort of that covered. But then you still have to utilize other medications. You have to utilize other therapies to calm down that hyperactive amygdala, to retrain that hypoactive prefrontal cortex, and to give the mesolimbic dopaminergic pathways the ability to regenerate the dopamine receptors. So you've got to do things like, you've got to do other treatments, other management solutions. Those are listed there, and you can read them on your own. And then risk management, I think if you are doing buprenorphine, you understand what risk management and opioid prescribing is. You want frequent visits. I do refills only with visits, so you have to be seen in order to get a prescription. If you miss your appointment, you don't get a refill. If you lose your prescription, you don't, I didn't write that, but you don't get refills for a lost prescription or early refills. Yeah, so no replacement of lost prescriptions or stolen prescriptions. And then I do urine drug screens every time they come in. And it's not random, so that decreases probably my sensitivity there, but I think it's better than not doing them. And then I do a PMP check every time they come in too. And I initially start, it kind of depends on their risk, but if they're kind of a higher risk patient and I'm switching over to a buprenorphine product, I'll probably see them weekly. And then kind of similar to when I'm doing buprenorphine management, I'll transition out to monthly at some point. And then the last piece is you change the plan when stuff happens, right? And we do that all the time with other things. I think sometimes we get stuck in our, well, this is our chronic pain plan, and if this isn't working, then, oh my gosh, they must be addicted. And, I don't know that that's necessarily the case. I think you take it on a case-by-case basis. But so you think about, so when stuff happens, what I mean with stuff is really, I mean aberrant behaviors. Is it overuse, whether it's overuse, or if they have an overdose, or if they have a urine drug screen that doesn't make sense, or they've missed appointments, or they're not following through, or if they have a pain flare, if they have a flare of their underlying mental illness. I think every time there's an overuse or an overdose situation or something in their urine, you have to ask, is this opioid use disorder? Does the diagnosis need to change? If the diagnosis changed, does the plan need to change? Do we need to get them onto Suboxone? Does this change the risk profile? Like, if you can't really say, yeah, that this means that they meet criteria for an opioid use disorder, does it change the risk profile? Does it increase the risk profile? And do we need to change the product? Meaning, do I need to get them onto a buprenorphine product, or do I need to change the taper length, right? If there's an overdose, something needs to change. Probably they need to get on some sort of buprenorphine product, but it's a case-by-case basis. If there's something in their urine that's not, that we're not predicting, or if they falsified urines, or if there's no medications in their urine, the prescribed medications aren't there. Again, is this a substance use disorder? Does this change the risk profile, and do we need to change the product or the taper length because the risk profile has changed? Missed appointments, they don't get refills without appointments, and the first time you do that is generally the last time they miss an appointment. Not following through with adjunctive therapies, you need to figure out why, and you need to change the plans if needed. So say maybe they just didn't like their physical therapist, or maybe that was the wrong physical therapy management style for them. Or they didn't really like that therapist and they need to talk to somebody else, or they need to be in some more focused pain psychology or something like that. And then you just need to reinforce the importance and work with, work with their, what's the word I'm looking for? Work with them. If they have a flare of pain, you have to be prepared to give advice and direct appropriately. So do they need to do something different? But you have to understand pain and body mechanics a little bit to be prepared enough to do that. And then you have to be prepared to treat anxiety and depression. And I think some people get caught up in, well, that's not my job. That's not what I do. Or maybe they should go see a psychiatrist, or maybe they should go see a pain doctor. And I think if you're the person that's going to be doing this, I think it behooves the people that do this to understand what's going to happen when we taper and what's going to pop up, and be prepared to treat those things. But whenever any of these things happen, I think you just need to understand the context and roll with their resistance. So that is my talk. I'm sorry that took so long. I will definitely have cases next week and I'll be here for talking about cases. So I don't know if there are questions, or if we have any time.
Yeah, we have some time. I think I know lots of people oftentimes have like 1 o'clock patient slots that are coming up. So I'm just going to kind of rehash real quick. First off, again, thanks a ton, Anne, for joining us. It's awesome. I think super hot topic that lots of people are interested in. Again, just kind of rehash for people that may have joined after we started. Next week is going to be all cases, kind of following up on the didactic that Anne gave. So Anne's got a bunch of cases that she can roll through, but I think this is exactly the ideal time to bring some of the cases that you're talking about, thinking about, and say, like, how can we really hash this out? Just in terms of this is how we learn. So please bring cases. On the email that you got from Roxanne, it has a link to the online case presentation form where you can just kind of fill it in at your leisure, just the details that you think are most important. So please share cases, and next week is just going to be all cases. Any questions for Anne?
I have one.
Yeah.
Great talk. Thanks. And my question would be around logistics when the person does not make their appointment, but yet needs more Suboxone.
For opioid use disorder?
Yes.
Or for?
Yes.
Okay. I mean, I look at the context, I guess. I mean, if they don't make their appointment and this is the 14th time they hadn't made their appointment or even the 5th, I kind of put my foot down. If it's, you know, they've been my patient for a year and they've never missed an appointment before, I usually generally fill it. But you know, I'm not a hard and fast sort of person, and I've definitely melted over the last several years. But initially I'm pretty hardcore about it. If it's a pain patient, it's a little different. I'm a little bit more like, well, you know, you missed your appointment, you know, because they're not going to go out and use drugs, as far as we understand.
Yeah, thanks. And I see a question from Beth Bilden. I don't know, Beth, if you can, do you want to just jump on and share your questions?
She's having trouble.
Otherwise, it sounds like she might be having some trouble on her mic. So she asks, where do you think Sublocade falls into the list of products or your thought process? And longer acting.
Yeah.
Yeah. So start there.
So Sublocade, I mean, it's only approved for opioid use disorder, not for pain.
And to sorry, Anne, just 1 second, to take a step back, for folks that may not be, it's relatively new to the market. Sublocade is an injectable depot formulation of buprenorphine. So it's almost like an insulin injection. You kind of like pinch the fat in your abdomen, and then you do the injection. So there's only 2 doses of it, 100 milligram and a 300 milligram. There's actually not a great set of equivalency studies, but it lasts for about a month. So I think people are still finding out a lot about it, but I'm curious your thoughts, Anne.
Yeah, thanks. Sorry, I should have said that. My thoughts are that it's a huge pain in the butt to get covered. And we're running into that in my clinic. We are banging our head against the wall because there are some patients that are really, really good candidates for it, but we just can't get it covered. But anyways, or we're trying hard to get it covered. But I use it for patients that just can't get it together on sublingual buprenorphine. Like they just can't stop using, or they just can't take it every day. That's my sweet spot for and so like I have one patient who's really, really depressed, and that's why she can't take it, or she misses her appointments because she's just really depressed. So for her, but she hasn't used in a year. But she goes through these cycles of depression because she doesn't get her Suboxone if she doesn't make her appointments. So that's kind of my sweet spot with Sublocade.
Got it. The other question that Beth had was, do you do point of care urine drug testing, or do you do send out, or what's your flow for urine drug testing?
I do point of care with pain and addiction patients, and I have at Health Partners in the pain clinic, I have sort of a, what's it called, where you like answer questions, and then if the question doesn't, like, are you prescribed this? Are you prescribed this? And if the response doesn't match the results, then it automatically reflexes to a confirmation.
Oh, interesting.
But yeah, so I generally get the answers within 15 minutes for both.
Got it. Other questions?
I had a question, Brian. This is Lori.
Yeah.
Hey, Anne, great talk. Thank you.
Yeah, thanks.
When you're working with patients that have chronic pain that are on a very high MME with no history of aberrant behaviors, people are so attached to their short acting that it can be hard the first time that you meet with them to convince that you're going to come down on that and totally off before you hit the long acting. Are your patients like coming to you from referrals from pain clinic, and so the prescriber for the pain medicine is saying you're going to go to Dr. Pilkus and this is the way it's going to roll? Or how do you get the patients to buy in on that?
Yeah, that's a super good question, Lori. It's a combination of both. I mean, a lot of times I'm the last stop on the train, you know, like they've burned through so many other pain clinics or whatever that they're not going to get opioids from anybody else. Sometimes I just sell it really hard. And I sell it really hard on these things, especially these ups and downs are making it worse. And so I can just sell it on that. But it's kind of a combination. And sometimes it's just like, sorry, this is what we're doing and you'll feel better. But, you know, and I know you're not going to believe me today, but, you know, within a couple months, you're going to feel better. But yeah, so sometimes it's a combination of kind of convincing and forcing.
And to build off that, I'm actually curious, when you first see somebody, first visit, are you decreasing right then, or do you kind of have an intro, here's how that's going to go, or are you kind of walking in and saying like, and we're stopping now?
It's the first visit it happens, but it's usually they've gotten a little bit of an intro by whoever is referring them to me. So it's not always super consistent, but now I've been here for 5 years, so all the pain providers know me and know what I'm going to do. So it's a little bit of both, but for the most part, sorry, it's not a little bit of both. For the most part, yes, I just switch over all in that one visit. Yeah.
Any other
I know
questions?
it seems hardcore, but if you explain it in a way that patients don't mind it, then it's not as bad as it seems.
And on that note, I think that's kind of the magic that is oftentimes like we say, like, and you just do it. But like, I'm curious, like the specific words you use, or do you like have a graphic that you oftentimes show patients? Like, what are those words that come out of your mouth? Or what's the picture you draw that you're saying I'm selling?
I draw the picture. So my big picture that I draw is the roller coaster. I like, this is what your pain meds are doing to you. You are going up and down and up and down and up and down all day. And the grand majority of patients say, oh, yeah, I am. You know, and then I say, okay, well, I don't want you to do this because I don't want you to be all the way down here ever. I want you to be kind of flat throughout the day, because the flatter you are throughout the day, the more consistent levels that your brain sees, the less that it's going to have these negative changes, right? And because I've explained these negative changes to the patient. And I want you to have a 24-hour consistent dosing, because they know what it's like to wake up in the middle of the night in withdrawal. And they hate that. Or not necessarily in withdrawal, but in terrible pain, because the Dilaudid that they took at 10 p.m. isn't there anymore, and they don't get another one until 8 a.m., right? So they're excited to say, yes, I want 24-hour consistent coverage. And even their OxyContin that they take twice a day isn't covering them. So, I mean, it's just understanding opioid mechanics is really, really important. And they get it because they live it, but they don't know, but they think that doctors don't get that, because that's not how we prescribe them. We don't prescribe them in a way that makes sense to their bodies, right? So having them understand that I will give them 24-hour coverage, and at the end of the day, yeah, we'll wean them, but we're going to go really slow, and it's going to be, you're going to help me be in the driver's seat, and we'll work together, and we'll treat the things that come up, and we'll get you to the right pain provider, or we'll get you to the right therapies that will help manage the pain as we're tapering. Because the biggest question I get is, well, what are you going to do about my pain? You know, and I think one of the other things I think is really, really huge in pain management is agency. So learning how to give them back agency over their body, right? So that they have control. And I talk about that when I see patients the first visit, is that they need to take control of their body back, because the pills have the control now.
Ooh, that's good.
I like that.
I know, right?
Yeah.
Well, I like how you're giving hope for increased function and increased improvement in their quality of life. So I hear a hopeful approach to helping things improve for them.
Optimism.
Yeah.
Right.
Therapeutic
and
optimism.
I cannot tell you the number of patients that I have that like feel way freaking better off opioids. Like I can't tell you. There's a ton. and they all want to tell other patients, but I haven't gotten to the point where I can like start a group or whatever where they can share that story. But I think it's a super powerful story. But once you have that experience as a provider of seeing patients that actually do way better off opioids, it's way easier to sell it.
Yeah, and the comment that Helen just made was like ditto benzos.
What'd you say?
Helen just made the comment ditto benzos.
Oh yeah, totally agree.
And perhaps that'll be a conversation for next week.
Yeah.
The benzo opioid combo, super hard, especially for this patient population. I just want to kind of highlight a couple of things. One, you can kind of see in the chat function, but also we can send out an email, some of the handouts both from today, as well as some of the diagrams that we've gone over in the past that highlight kind of a graphic that's like what Anne was talking about, is like what patients, this is what I just commonly draw for patients on that roller coaster where they're kind of feeling the ups and downs of how their body normally makes it. And then there's like animation, so it's not like this crazy graph that you see there. But essentially it's like how people can then, their bodies compensate, and oftentimes by the end of it, when they get exposed to all these the ups and downs of the roller coaster, when they take their meds, they're just getting back to feeling normal. And that's one of the hardest parts, is when you're on chronic opioids, the absence of opioids feels like pain. Mm-hmm. And so then it's just kind of this mix of, is it the absence of pain or is it just the underlying pain, which is just where people anchor. So just final time, again, thanks a ton, Anne. Looking forward to next week where we can discuss a bunch of cases. Any final thoughts that people have or questions before we kind of wrap up for the day? Awesome. So again, please send in cases. There's that link. If you have any questions or you would like some help or support, we're more than happy to kind of reach out to you or kind of figure out how can we help you support or start prescribing buprenorphine in your clinic, whether it be thinking about chronic pain or particularly opioid use disorder, where this is really kind of the life-saving medication for lots of folks around the state. So please let us know how we can support you. And then we will connect with you guys again next week. Hope you guys have a great one. Take care.
Thanks, Brian. Thanks, everybody.
Thank you.
Oh, thanks. Bye.
Oh,
What's Frostbite Falls?
it's cold.
Cold.
I was telling Brian, I'm in Baltimore, actually. It's dangerous. I've been shot twice.
No, birds just heard. Take a towel.
It was right here, yeah. Once in the back, but no. So, Brian, you actually looked at that case, huh? The case at the Supreme Court case?
Yeah, I've read through a little bit. So for folks that aren't aware, so Kurt's referencing this, there's a recent Minnesota Supreme Court decision, Warren versus Dinter. And so what the issue at hand was, where the case came from is there was a nurse practitioner who had a patient who called a hospitalist that would have been the admitting hospital to just say like, hey, what do you think? The hospitalist, without no kind of, like there was some case specifics, but like it was all kind of de-identified, didn't look up like the patient's chart. There was no contact between the hospitalist and the patient. And after that kind of what's commonly described as like a curbside conversation of what do you think, the hospitalist said, I don't think the patient needs admission. The patient ended up dying. Septic, yeah, and then deteriorating and bad outcome. And so the case then went to the Supreme Court because the patient's family then sued the hospitalist. I don't know if they sued the nurse practitioner as well, but included the hospitalist in the case. And then Minnesota Supreme Court recently found that the hospitalist was at fault and found liability for the hospitalist, even though there was no patient-provider relationship or ever any actual interaction. And so this, as you might imagine, raised some flags for lots of people. So like, are you saying that you can never curbside and make any recommendations when you don't have a relationship with the patient, because now I might be held liable for something that I didn't even do, but because it may have influenced your thought process, now this has liability because I'm now a third party, which is like, depending on how you interpret the case, and this is where like that general principle may be extremely threatening to echo, like when the whole point of this is like case discussion. Like, I think this is where kind of the gray line people are trying to figure out, like, how do you think about Warren versus Dinter and that judgment in the context of like medical education? Like, that is essentially how all medication happens. That said, in most medical education, there's already a direct like attending with a learner, so that you're all still having direct patient relationships. But the whole context of like, how do you do generalizable learning like this? Like, if we're making case recommendations and somebody presents a case, we talk about it, are we now liable for having a conversation that may impact that patient's care? And so I just kind of wanted to highlight, like, I actually pulled up parts of it in front of me here. And I think it's actually really helpful to look at the judgment. Because they say, first off, the most concerning part that I think flags everybody, they're like, to be blunt, it's like the oh shit moment for all providers everywhere, is the first sentence of the summary is, a physician-patient relationship is not a necessary element of a claim for professional negligence, which means I don't have to have a relationship with the patient in order to be charged with professional negligence, which is like, are you serious? Like, I mean, that's where everybody's kind of like the oh shit moment for like Echo and everyone. But I think the second sentence is actually kind of a nuance to it, is a physician owes a duty of care to the third party when the physician acts in a professional capacity and it's reasonably foreseeable that the third party will rely on the physician's acts and be harmed by a breach of standard of care, which means, how I interpret that, and this is me not being a lawyer, is that the duty is when there's a foreseeable expectation that that physician who's the third party would be involved in that patient's care down the road. And that's where I think that separates from Echo, is people aren't referring them to us, and we're not making a judgment, should that patient get referred to us. We're just saying, here's a case discussion that you can learn from. Because part of this was the hospitalist, the physician said, I don't think that patient needs to be admitted, but I would be the one that would be taking care of that patient if that patient was admitted. And so it was the hospitalist saying, I don't think that patient needs to come. And so he is then the third party that's actually would have been part of that care cycle for the patient. Whereas we're not going to be that care cycle. We're not asking for referrals. This is really just third party conversation amongst the general community. In fact, we're saying, like, you can take care of your patient there because otherwise that patient's never going to get care. Because, like, let's be honest, people in Ortonville aren't going to send their patients all the way to Hennepin or to Little Falls. People in Ortonville are going to stay there. So how do you take care of your patients in your community?
Additionally, this physician who was consulted impacted the patient by having them get less care.
Right.
And what we're doing with Echo is encouraging people to get more care.
Right. And so then that's where the second point of the summary was, viewed in the light most favorable to the patient. It was reasonably foreseeable that a patient seeking admission to a hospital would rely on the hospitalist's acts and be harmed by a breach of the standard of care, thus making the summary judgment of the hospitalist improper. And so again, it's saying, because that patient would have ended up with the hospitalist, then that if that patient had been in the hospitalist's care and had that same discussion, the hospital said, I don't think it's an issue, then they would have been a breach of care, and that would have been improper standard of care in the court's finding. And so that's where, because the patient's not going to end up in my door anyway, and we're trying to help people take care of their patients in their community, if they're like calling me and saying, hey, I want to get like a referral, that's a different story. And now we're talking about, like, do you want to send your patient to my hospital where I would be caring for them? Whereas right now we're talking about, like, here's a case that I'm dealing with in my community. How can I help you take care of the patient in your community? So that's how I've interpreted it in conversations with Gavin. To say I don't think Echo applies, but I get the concern, because that first sentence is where, if you like put all the weight on this whole judgment just on the first sentence and not the entirety of it, holy crap, like a relationship is not necessary to be professionally negligent. Like, I'm not talking to anybody.
Right.
And I,
Doesn't Ann say always consider the context?
yeah, so I think that's how I'm interpreting it, Kurt. So I think, but I get it, and I think we do have to be concerned about like the nuance of how we convey. Like Kurt and I were kind of texting back and forth beforehand. Like, when we send recs, if somebody presents a case, I'm no longer going to say like we're putting together a summary of recommendations. And we're going to put together a summary of the discussion that was had.
Yes.
Because I'm not making recommendations on care. I'm just saying like these are things that you could consider from like this team. And I think
discussion points.
Right, exactly. And that's where I think it's just some of the language around it may have to change.
Yep. Because when I see a patient directly in the clinic for consultation, I say recommendations for the PCP, but that's based on my seeing the patient.
Right, exactly.
And examining the chart and doing a more in-depth,
exactly,
personalized search.
Yeah. So I think that's how I'm interpreting it, Kurt. I don't know, how are you guys thinking about it?
Yeah, you know, we've been kind of kicking around if we're going to actually put up a disclaimer before we do the case that, and it says something similar to that, you know, and I think changing it to not say recommendations is a great idea. To just say this is some of the things that were discussed that you may consider. But you know, I think that just to be vague. And again, I think that whole thing about saying, well, if I was seeing a patient like this, I'd probably be looking at these types of things, you know, as opposed to saying, I think what you should do is this. I think we have to be careful saying that. What this person needs is exactly this. I think we have to avoid those statements.
Yeah, I agree.
So it sure caught us by surprise when we read that. It's like, wow.
Yeah, when the first case first came out, I was like, whoa.
Yeah.
I mean, you just hear about that and you're like, are you serious? Because, I mean, I sometimes work as a overnight like medical officer of the day where I'm making judgment calls on if you should transfer a patient or not. And I was like, holy cow. Because you're totally reliant on however they spin the story to you. And
I think one of the problems with that case is that we all know that, and you know, in some smaller communities, when the hospitalist doesn't want to work, it's much easier for them to say, I don't think that needs to be admitted because they're already busy. And, you know, that's just the reality, you know, especially in these hospitalist kind of smaller communities. So, yeah, that's a tough one.
Yeah.
Are we acting in a professional capacity here, or are we acting in like an educational capacity?
You are a professional. You present yourself as an alcohol and drug counselor.
But it seems like in this, I don't know.
You have a
It seems like in this case they're making a distinction there somehow. Like you have to know the person's going to listen to you. You give the advice, and you have to know that the advice is bad, and then that the person's going to be negatively impacted by it.
Well, you don't know that the advice is, I mean, that's something that just like it goes out down the road. So like we can say you definitely like, in theory, you can say that patient doesn't sound that serious. I can't see the pain generator. You should definitely taper the opioids fast. You know, opioid taper goes fast. Patient uses heroin overdose, dies. Who's at fault? You know, right now the legal system is saying like, you know, you're more likely for continuing to prescribe opioids and the patient dies. Now you can be held liable. So I think in general, what we're recommending is all life-saving. We're not saying prescribe more opioids. So I think in general, our risk is really low. Like we're not doing like a, you know, an ECMO echo. You know, if I was doing an ECMO echo, then we'd be all screwed.
What's ECMO?
Exactly.
There you go. We don't know either.
It's like for heart lung transplant surgeries.
Yeah, essentially you mechanically take over their lungs and heart. So it's more of the story that like we're not doing something that's like super high risk. I think in general we're pretty safe in general, but like to the point of the principle of it, is there any risk for what we're talking about? I think that's how we've so far interpreted it. I'll be honest, I have not brought it to our legal department because I don't want them to be super conservative and say no. Which they tend to do here.
So we're PCBH is having conversations with legal about it because we do. That's what our work is consulting in primary care.
Yeah.
That's all I do.
Yeah.
So we'll see. But I think we're helping patients get care.
And this is a different model from that. So I think that's where, at least that's how we're approaching it, you know, for better or for worse. That's kind of how we're thinking about it right now.
All right.
I'd be curious.
Well, I better get going.
I'd be curious what you guys come up with for a disclaimer.
Yeah, we wrote about 10 different things down, trying to figure out how to make it kind of like, you know, middle of the road, but yet this is not advice. These are discussion points for the patient, you know?
Yeah.
Well, I'm gonna talk now.
Uh-oh.
Heather's on.
Katie, my video is off because I am not working and I am currently eating cereal.
Didn't you videoed in from the treadmill once?
I know, but I think I'm cuter when I'm running than I am right now. But we just had a call and Kurt was making fun of me, so I couldn't let him see me again. So a lot of the disclaimer part basically just said, you know, this is not an exhaustive list of collaborative recommendations. You know, in any event, if you feel that this is too, have confusion or blah, 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 or you don't exactly know what to do, refer on to a higher level of care is, you know, the final cop out.
Yeah. And are you guys going to present yours to your legal, or are you guys just going to do it?
We were going to post it yesterday, but we got in a huge fight yesterday morning and didn't have time, and sorry. And I think we're going to show it to our legal, or at least Rhonda, the administrator, just to see is this something that is helpful or no.
Yeah, that's a tough call because I don't want it to somehow change what we do. It's really a tough call.
Yeah.
I mean, there's risk with everything. If I ride my bike in the morning and it's a little dark, yeah, I could get killed. But
you're in Baltimore.
Or
not riding my bike in Baltimore.
Just like being in Baltimore.
A transatlantic swim. So,
Then they said going to Annapolis.
So
Annapolis is beautiful.
Is it? Yeah.
Oh, yeah, I used to live there.
I'm just going to get out of here. That's all tomorrow morning.
Eat some crab cakes.
Yeah, definitely.
Good night. Yeah.
All right, guys.
All right, well, I'm going to get going. I'm do some other fun things, but we'll let you know when we come up with something. I don't know. It's kind of a tough call, but we're going to come up with
kind of disturbing.
Yeah. Cool. We'll see you guys. Take care.
See you guys.
Yeah.
Hey, Cam.
Yeah.
By the way, Cam, I couldn't wear those pants, Cam.
Yes, you could. All you gotta do is put them on, man. You can totally do it.
I'm just going to say this once. If I wore those downtown Little Falls, I'd get my butt kicked by somebody. Some guys who come out of the bar, they just beat me up.
Next time I'm out in Little Falls, I'm wearing these pants. You have to have my back, though.
Deal.
Cam, too flamboyant for Little Falls.
That's right.
All right, see you guys.
All right, take care.
I'm proud of it.
Yeah, bye.